Thank you for introducing me. The presentation which I'm about to present is entitled Nurse-Led Models of TB HIV Care in South Africa. Mycobacterium tuberculosis is the leading cause of death for people living with HIV in South Africa. As such, one of the studies suggested that only 52% of TB HIV co-infected individuals have successful treatment outcomes, with many failing to be linked or retained in care. There are many reasons which are linked to the unsuccessful treatment outcomes, inter alia, loss to follow-up, pill fatigue, side effects, and many more. As a result, all oral MDR TB regimens are now standard of care throughout South Africa, simplifying the potential delivery of such care. However, the strategy which South African government embarked on, among others, is nurse-initiated management of MDR TB, which is recommended by the National Department of Health based on evidence, which was an observational evidence in South Africa. This model illustrates the journey of the patient from home to the health facility, which demonstrates the problems that the patient encountered. I will take you through. This client will be coming from the rural areas of South Africa. As you can see, this Rondaville. Here, it will depend on the individual resources, the transportation. For example, if the client is having some money to go to the next level, the health status, is this client not very sick to travel? And the employment requirements, is this client who is becoming sick employed, and the family duties of this client, many more. Now, if this client has happened to have some resources and travel to the primary health care, you can see how this primary health care is overcrowded. And here, this client, it will depend to the clinician competency and as well as the diagnostic capabilities, meaning the client, the clinicians might be able to diagnose this client, but not having enough resources to treat this client. Then they will decide to transfer this client to the next level, which is the hospital. In the hospital now, it will depend to the bed capacity and the availability of the healthcare workers. Previously, only the doctors were allowed to initiate the treatment for multi-drug resistant tuberculosis. And another thing, in the same hospital, it will depend if this client is, there are some drugs available to treat this client, and they still here, we're still talking about the clinician competence, because some of the doctors were not having an understanding of multi-drug resistant tuberculosis. Down here, you can see the stages. Once this client, which is coming from this rural area, is in the healthcare facility, here now, there are a lot of stages that this client will be traveling through. For instance, this client has to go for chest x-ray, and after the chest x-ray, lot of papers that need to be filled, and this nurse will also prescribe the treatment, which is a lot when it comes to MDR TB. In any case, this sister, which you can see here, is Sister Khaya, who is actually presenting now. This brings a question of how can we make care more accessible to patients throughout South Africa? And another question was, what are the training needs for successful implementation of this model? An evaluation of a nurse practitioner physician task sharing model for multi-drug resistant tuberculosis was conducted in South Africa. This study was done by John Hopkins School of Nursing, and the principal investigator was Professor Jason Farley. It was a CDC-funded, pragmatic, innovative to increase access to drug-resistant tuberculosis treatment. It was a retrospective cohort in one hospital with 197 MDR TB clients which were recruited, a median age of 39, and about 51% were females. And you can see the co-infection of HIV, it was 74%. And automatically, those clients with a low BMI were receiving care through the physician-based treatment. And the duration of treatment was 24 months. Here is clarifying the patient's characteristic by provider type. You can see the overall as in the previous slide, which is showing 197. And here the CNP was assigned 123 clients, and the medical officer was having about 74 clients. This is clarifying the BMI for both a CNP and the medical officer. You can see it was ranging between 6.9 to 22, and on the other side, starting from 14 to 21. Now, here is the clarification of these patients which were presenting in the MDR-TB. Initially, the number was 212. But some of the clients were transferred to another care, like to another hospital, because maybe of some complications or the client has a further resistance. So about 15 of those clients were excluded, and the total number of the clients for the final analysis were 197. In these two is just a clarification of the distribution of patients. CNP was assigned, as mentioned in the previous slide, 123, and the medical officer was assigned 74 clients. You can see the median age on both sides. There's not that much difference. Even the only difference in these two patient assignment is the BMI, as mentioned in the previous slide, that the medical officer was assigned with the patients with a low BMI, and the clinical nurse practitioner was assigned with a BMI which is above 18. In treatment outcomes, this slide is actually showing that there was not that much difference in the treatment outcomes for both the clinical nurse practitioner and the medical officer. With the treatment outcomes of, for example, you can see the cure rate here on this side for the nurse, which is about 75 patients, which was 61%. And on this side, it was 52.7 for the medical officer. And even with the treatment failure, there was not that much difference, 4.1, 8.1%. Definitely for the doctor, because the clinical nurse practitioner, once it sees that there's a problem with the client, this client will be transferred to the medical officer. So the medical officer was getting more of those clients which are having complications. Now, to overcome what was happening on top, we decided to start preparing the healthcare workforce. This preparation of healthcare workforce in South Africa was a short course. It was for the short course rifampicin-resistant TB treatment, interprofessional training, and task sharing consideration. It was a 4-day didactic and a case-based clinician decision support for rifampicin-resistant tuberculosis regimens in South Africa. And this training was developed by Johns Hopkins School of Nursing and was accredited by the South African National Department of Health. About 12 trainings were conducted between February 2017 and July 2018. The category, the cadres for this training, it will be the physician advanced practice nurses, meaning that the clinical nurse practitioners and the professional nurses. In South Africa, there's a difference between a professional nurse and a clinical nurse practitioner. It depends on the training that one has undergone. And nurses with full demographic and pre-post and data were analyzed. And pre-post test included 25 clinical-based questions on rifampicin-resistant TB management. Now, in this slide, you can see the participants' characteristic. The total number was 762. The tests were meshed, meaning that a participant will be having a pre-test and a post-test. Now, looking at the medical officers, you can see the number of medical officers and the age of the medical officers with different ages. And the advanced practitioner, practice professional nurses, which is the clinical nurse practitioner. You can see how many were there, and then the professional nurses, which made the total number of 762. Now, good with this training, it showed that in the pre-test scores, the medical officers were having higher scores because they were already having a bit of knowledge about MDR, whereas the professional nurses and the clinical nurse practitioners were having low scores. But when we actually did the training over this 4-day period, on the last day of the training, that's when we were giving the participants the post-test, and then we discovered that all the participants were getting higher scores, meaning that even the medical officers and professional nurses were almost on the same level after the training, this led to actually decide for South Africa now to give access to primary healthcare nurses to start nurse initiation at a primary healthcare. Thank you. Any questions or comments? And this acknowledgement is the South African team, as you can see in this slide. I thank you.